we know that that's going to be a blockage. They're going to have those same handouts like I gave you, same symptoms on the handout. We strain their urine, we push fluids on them, we might give them antibiotics, okay? Renal tumors. This is really sad. You see a lot, this is not as common, but they do get tumors on their kidneys. Family history usually plays a lot into it. Hypertension, because their kidney tissue isn't getting enough blood flow because they have high blood pressure. And then they may have a horseshoe kidney shape, things like that. But smoking usually is a #1 cause of kidney problem, kidney cancer or bladder cancer. It just settles there. So just kind of know if they're a smoker and they're having, that might be one of the clues they give you. They're having kidney issues. Do y'all know how they check for the prostate? How's the doctor check? You wish one finger. No, sir. So if you have a BPH, benign prostatic hypertrophy, they'll go in. Because remember your anatomy, this is benign prostatic hypertrophy. Hyper meaning overgrowth, right? Hypertrophy. And they're coming in, they're saying, I got a trickle and I can't, have relations with my wife or whatever they want to word it as.
Well, sorry, we got it.
Yeah. And so after we do, a few tests, and they realize, this PSA, PSA is the lab work they draw, right? That's for the prostate. That's the lab level they draw to see if the prostate's elevated, the hormones and stuff. So they'll check that, and then they do an exam. And they have to, bend over, and they do it rectally. They're feeling around because that prostate anatomically on a man is close to where there's a fine wall between, the rectum and where the prostate is, so they can feel it that way. Because it's internal, but they can get there and kind of feel around. And if it's real boggy, it should feel soft and spongy and elastic. But if it's boggy and not bouncing back, then that's enlarged. And so that's when they start thinking, he may have prostate problems. So just kind of know that it should be soft, spongy, and elastic and bounce back and not hypertrophy. Okay? Boggy's not good. And then they do a TERP if they, end up having that. And I gave you the handout on that, right? Okay. When you have somebody who's having urinary disorders, no matter what kind, if it's just from stress incontinence to down to, enlarged prostate with sexual dysfunction, that is a huge, huge mental game on people. Nobody wants to laugh and pee on themselves. Nobody wants to not have sex with their partner. It messes with their head. So you need to be a real good, nurse and be real holistic. You're treating them not just their physical symptoms, but their emotional symptoms. Encourage them to talk about their feelings, especially how this is going to affect their relationship. If they're in a marriage and things aren't happening, one of the partners could feel rejected, not realizing that there's something wrong. And that other one that has the physical problem won't voice it, and so now there's a marital problem. They think he's cheating, or she thinks he doesn't want her anymore, So stuff like that. So just kind of be real listening without judging, supportive, and providing privacy and support. Not just physical treatment. You're doing the whole patient, emotional and psychosocial needs, all that. Okay. What would some nursing diagnosis be? They always like to throw those out. What would be the best nursing diagnosis for somebody with urinary, or just throw some out with urinary problems? Impaired urinary elimination. That's easy, right? That's easy. That's broad. Anything impaired with the urine. Impaired renal blood flow, pain, sexual dysfunction. What about if they have a bag where they've had to have a urine, their bladder had cancer, now they have a collection bag? How awful would that be as far as your body image, right? So altered body image, things like that. Okay. Now let's say they're on dialysis. We've kind of talked about what led up to it. They've had all these issues, and now things aren't working. Okay, the kidneys have just pretty much starting to shut down. First, they can do, it's on page 1715 in your book. They can do hemodialysis. Well, let's start. Let's see which one would be easy. Let's start with hemodialysis. Hemodialysis is where they're just cleaning the blood, right? Dialyzing the patient because the kidneys aren't doing their job anymore. They're not filtrating. So they put a shunt in your patient. Has anybody had a patient with a shunt in their arm? And it's like a little two-way port, basically. Taking the blood out and then putting the clean blood in after they've been dialyzed, okay? Real important to make sure that that shunt is functioning. They always put it in a non-dominant arm usually because that way they can still do everything with their other hand. And then you don't want to take what in that arm? Blood pressure, IV sticks, anything like that. You use the other one. Good. Don't want to compromise that shunt because what is that basically? That's their kidneys. That's their lifeline. Is taking the toxins out. So make sure that you're, feeling for the thrill. Have they ever taught y'all that? You feel it and it feels like you can feel the blood terminating over it. So they call it a thrill. It feels like a cat purr. You ever felt a cat's throat when they're purring? You're looking at it like, I don't like cats. Okay. They're like, and that's how it feels right there. And so you'll feel it to make sure that means it's patent and it's working. And make sure that like you said, don't take blood pressures or sticks in there. If they're having, check it just like you do an IV site. Does it look red, inflamed, drainage, streaking? You need to notify the doctor because we want that free of infection. Okay. All right, so here's another handout. We're going to start talking about dialysis real quick. Who needs dialysis? These are patients who, like I said, they've kind of already gone through the gamut. They've had kidney problems for several years, and their kidneys are just playing out. So now the only thing left to keep them alive is dialysis. We have to dialyze them. We have to clean their blood for them because their kidneys aren't doing it. So they may be somebody who has acid-base problems, like usually they are, because if their kidneys aren't functioning, which kind of acidosis or alkalosis is that? Which one, though? Metabolic or metabolic? Because they're not cleaning out stuff, so they have a buildup of things. So they're going to have acid-base problems. So they come in and they're like, you do their ABGs and they're all out of whack. All right. Then you start. That's one piece of the puzzle. Then you start looking. You do some blood work. Their electrolytes are all elevated. Sodium, potassium chloride, all that. They may have other issues like if they're taking their drugs or meds and they're all toxic on them. Because what's happening? A lot of pharmaceuticals are broken down by the liver and what? The kidneys. So if your kidneys aren't working and you're still taking your pill every day, what are you going to be? Toxic on those different meds. So they'll check all that to make sure. And if they're elevated, that's another check on the box. They may have edema, right? An overload of fluid. So they're short of breath, they're swelling, they're real, they get winded and they get tired real quick. They have an overload of fluids. That's another person who might need dialysis. And then the uremic symptoms. They have the uric acid comes out in their skin, and it's uremic frost, and it's like their skin looks real ashy, not just like dry skin in the winter. I mean, it is like somebody dipped them in powder, and they itch. Has anybody ever seen that? I've had it one time, and it was a little old elderly man who was real sick. And I didn't know what it was. I was a new nurse, and I said, "What is all over him?" I was like lotioning him up, and they were like, "Honey, that's uremic ash." And I was like, "Oh." So just know that's one of those things you might see. It may be in the description they give you for that kind of patient. Okay. So then when they determine that they need dialysis, they kind of decide which way they're going to do it. They can do it with the machine, like I said, through the blood, with their shunt, or they can do the peritoneal dialysis. Peritoneal, there's on page, what page is that? 17, 8, 16? Yeah. Okay, there's a picture of it. If y'all has anybody ever seen a patient with just the peritoneal? Most of the time they peritoneal dialysis. Yeah, they do that at home because they're not as sick yet. Literally the last stage is the hemodialysis, where they're going for dialysis through the vein. So they'll do peritoneal at home, maybe a home health nurse and an aide going out, but the patient has to be trained how to do it. And you take the bag of fluid, put it in, and then you lay the bag down and let it drain out. And that is helping clean their system out. It's done about 4 times a day, 7 days a week. Can you imagine 4 times a day doing this procedure every day of the rest of your life? Do you think they get to go to Walmart very often? No. There's no machine, and like I said, it takes about 30 or 40 minutes, and it's just using osmosis and diffusion, that basic science concept where everything is crossing over the membranes and it's pulling it out when you pull the bag down. If they've already had previous abdominal surgeries or some kind of inflammatory disease or maybe back pain, they're not going to be a candidate for that, because if they've had abdominal surgery, their anatomy's all moved around. So you're introducing something that might make more harm, right? So they don't get that. They have a catheter that's there and it's placed in the abdominal cavity, a peritoneal cavity, and the fluid is just instilled. They put it in there, they leave it in, let it sit there, and then they let it drain back out after several hours. What do you think they would be at risk for with us moving this fluid back and forth? Vital sign-wise, when you're tinkering with volume, what are you messing with? Blood pressure. So they're not going to be able to do this and jump up and run, are they? Because they're going to have that orthostatic hypotension, lots of changes, so we don't want to do that to them. We want to make sure we're monitoring that. Okay. And then on page 1719, there's a picture, I think, of a urostomy. Is it still in there? Maybe not. I don't know, I have that written down there. Has anybody seen a oh yeah, it's on there. This is kind of like a colostomy, where they resection the bowel and they pull it out, and instead of the bowel emptying out through the rectum, it empties out into a bag. That's a colostomy. So a urostomy, they do the same thing, but instead of having a bladder, and you can see the picture on 1719. So see the kidneys, and then there's a ureter, and then it looks like it's going to a hot dog. Do you see that picture? That's not a hot dog. That's part of their bowel that they have cut out, resection, and now they're using that bowel to connect to the outside of the body and empty urine through. So it's basically just a tube that's emptying, and that's the urostomy.
So they cut out a portion of it and then connect those?
Yep, they connect those back, and then they use that piece of the bowel, because it's still your own body, so you won't reject it, and it makes a tube out from the inside of the body to the outside, and then you have a bag that collects urine instead of stool.
Oh, okay.
And that sometimes they do that if they've had like bladder cancer, where there's no saving it, but they can, if it's still contained, they can take that out and put that on there. Okay, so you may see those on the floor when you're working. Okay. All right. So then, let's say they're still doing dialysis, but things just aren't getting better for this little patient. They're going into chronic renal failure now. All right. So let's start with this one. I have 3 handouts on this because it kind of progresses. Are you that sad about it? At first, they don't look too bad. They only have like 40 to 75% loss of kidney function. No symptoms, really. These might be your people who are diabetics, who are not really compliant, but they can still get away with it, right? Because they're still young and healthy enough. So at first, they think nothing to this. And then they start getting more sick, and it turns into a little bit more. 75 to 90% loss of their kidney function. That's a lot. 75 to 90% of your kidney. I mean, why even have them? And so now they're symptomatic, right? Because nothing's working, so everything's building up, and they will have some anemia. They're going to have headaches, obviously, because they've got that fluid overload. Decreased inability to concentrate urine, peeing all night, and then their blood levels are going to be high. Which blood levels are we checking for in a kidney patient? BUN and serum creatinine. Creatinine is made by your muscles, so every time your skeletal muscles. So every time you're walking all day long, that's a byproduct of movement of your skeletal muscles. Creatinine. Normally, it goes through your blood supply. Your kidneys pick it up, filter it, and it's excreted out. But if you don't have kidneys excreting it, then it builds up, and that's why they check BUN and creatinine. Okay, it's just a byproduct, and it just indicates again that they're not, kidneys aren't working. Okay. And then the last one's coming through.
Which one are you giving them copies of the last 3?
We're too short on all of them.
Okay, I'll get those numbers. So the last one is chronic renal failure end stage. Okay, now she's moved from I feel good, no symptoms, to I got a cane, to oh my God, get me in the lazy boy. All right, her kidneys are not working. She has less than 10% function. They're pretty much one foot on a banana peel, another one grape. They're dead almost. They're really sick. They're very confused neurologically. They have, because they're so toxic. All their cardiovascular stuff is through the roof, like blood pressure, edema, periorbital edema, extended neck veins. They've got fluid around their heart, so then their heart's giving them trouble. Their lungs are full of fluid. They have thick sputum because all that fluid is building up, right? They have an ammonia odor to their breath. Why do you think that is? What's urine made out of? And if you're not getting rid of it, that ammonia, it's going to seep out somewhere. Yeah. So they'll have that, how like diabetics have the fruity breath because they're sugary. End-stage renal smell like a litter box. It's terrible. Metallic taste in their mouth. They get a lot of ulcerations. Of course, they're sick and don't want to eat, and they have nausea and vomiting. Certainly, they're going to be withdrawn and depressed, so we got to really address those issues too. We take care of the whole patient, not just their physical issues.
I'm just seeing if I already had it. You said something about
Probably did.
Kings.
I'll give you copies in a minute. So, these are the people who are pretty much going to be getting dialysis every 2 days. Skin's real dry and flaky and itchy. They're anemic because there's nothing there to tell their red blood cells. Remember, our kidneys release chemicals that tell our bones to release red blood cells when we need it. Well, now our kidneys aren't working, so there's nothing to tell our bones to release red blood cells, so I become anemic. And then they have cramps because of the electrolyte imbalance. So it's a really sad little case when you see a patient like that. They go from really healthy and okay down to nothing. So those are just for your studying for dialysis. Did y'all have a lot of dialysis questions or anything about kidneys? Good. Maybe they will put it on there. Last one is just something extra for y'all to have. Kidneys and stuff to help you remember stuff. Okay. When you have it, this was a term that came up. I do remember this because nobody knew this on the test. Azotemia. What does that mean? Anybody know?
Oh, I know. Hold on, I wrote it down. Azotemia? It's, I don't know what I wrote, but something about running creatinine or elevated.
Yep. It's what
Level of conscious.
creatinine. Urine and creatinine are elevated. That's what that state is. If you have elevated urine and creatinine, that's the name they call it.
Why would and then decreased level of consciousness, disorientation, high blood pressure,
Urinary kidney failure.
Kussmaul's,
They'll have Kussmaul's because they're in acidosis. They're trying to blow off that acid.
and that's what happens if your binding creatinine is elevated. Oh.
Because your kidneys are failing.
See, that's what
Any questions on neuro? I'm trying to just kind of go back over and make sure y'all got. This is what she lectured y'all on already, right? Just. Come on, quit asking. Okay. All right, let's take a break and then we'll do case studies on neuro. All right. Catch up on whatever y'all need to catch up on. I know Cynthia there falling asleep. It's hard after lunch. Super hard.
No, I didn't sleep at all.
Why not? You know I'm hardcore.
She was worried about being late to class.
And then I had another one move in, and I have a mess. And I can't live like that.
Okay. So y'all need how many of all of them? Or just which ones did y'all not get? Did you get this?
The last one I got was.
Like there's still some coming around.
I guess the last 5.
I didn't need 20 minutes. No one came up with it. Just all the last ones. Okay, thank you.
Did you get the Did you get the renal failure, lady? You just need the 3 renal failure. this one? Did you get this one?
No. I did.
You did?
No, I didn't. I didn't.
This one. Okay. Just 3 sets.
Is that the last one you gave? And the one before that I didn't get.
So 4.
Yeah, you can't let me add into. Let's see, there was one before that.
She's got accent.
What did she say? She has to. Because Maria won't do it. Because I'm doing the thing. Oh, wow. Oh, that's it.
Do that. Be real. next week.
I'm sorry.
Happy Friday.
For what?
Next Thursday I'm with y'all.